Hi there, my name is Vic Veer. I'm an ENT consultant surgeon working for the NHS in central London, and I want to talk to you a little bit about tongue-based surgery. It was a little idea I just had at the end of the last video, so I thought I'd just mention it now here. So what I wanted to talk about was, firstly, I'll go back to that thing about the nose helping the tongue, which doesn't make any sense to people. And so how's the nose? It's not anatomically connected to your tongue at all, but in terms of physiologically connected, it is. So if you've got a blocked nose, people have to sleep with their mouth open like this. And people don't sleep like this, they sleep like this. And their jaw just falls right back and that blocks their breathing. So when I do a drug-induced sleep endoscopy, and there's some videos I'm sure you'll see on my YouTube channel about that. When I do a drug-induced sleep endoscopy where I'm watching people sleep to find out why they have obstructive sleep apnea. So I'm looking down there, seeing the back of their throat. And then I can see, oh, okay, he's got a blocked nose. He's struggling to breathe through his nose. I can see their tongue falling back. Then I can think to myself, well, if I close their mouth during a drug-induced sleep endoscopy, let's see what happens. If suddenly the tongue moves out of the way and they can suddenly breathe again, but they can't do that because their nose is blocked. They can't actually physically close their mouth at night because their nose is blocked. Well, then in that situation, what I'd normally do is say, look, let's unblock your nose, septoplasty, turbinate reduction, all those sorts of things that I talk about in these videos. And then instead of operating on your tongue, why not learn to sleep with your mouth closed? And that's quite useful. You can use a chin strap. I prefer a Knightsbridge chin strap, a dual strap one, because the strap is around this way at the front, rather than the ones that push your jaw back again. And you can buy that from the Hope to Sleep charity website from Kath Hope. It's a great forum on Facebook on there as well. So using the chin strap to close the mouth like that really helps. And once you've unblocked your nose, and you've worn this for a few weeks, sometimes 2 months or so, you rehabituate yourself to breathing through your nose again, and that way you can take off the chin strap then and hopefully sleep without it and everything's fine without having to operate on your tongue. But if you do get to the point where you need to operate on the tongue, in my head, I've got sort of 4 or 5 main things I look at. I mean, there's lots of variations of all of these operations I'll talk about, but these are ones I think about in my sort of ideas of what's going up in my ladder. So the first is that you may have not a tongue problem, but a lingual tonsil problem. And I'll try and explain that. So you've got teeth there, tongue coming down like this, back wall of your throat there, and your tongue is falling back and blocking your breathing. But it may not be the actual tongue that's falling back. It's the extra additional tonsil tissue sitting on the back of your tongue that we call the lingual tonsil. Sometimes your tongue falls back a little bit, as it does in most people when they lie on their back, but because there's extra tissue there, it's blocking your breathing. And so if you have that situation, you can just remove that lingual tonsil. It doesn't affect your immunity and things like that. And I'll talk about tonsils in my book and some other videos that I have. But you can remove that lingual tonsil. That should have gone at puberty. So you shrink all that stuff down. I normally use something known as a Celon Radiofrequency Ablation. And what you're basically doing is ablating it or cauterizing that area. When you cauterize it, it shrinks down because you get rid of some of the fluid in there. I think I've mentioned in another video, I talk about dehydrating a grape. If you dehydrate a grape, it goes from a grape this size down to a raisin, which is this size. And you still got the same fruit, but you've reduced it in size and it's no longer blocking your airway anymore. Grapes don't block your airway, but you know what I mean. So you're reducing the size because of that, but also it causes an awful lot of scar tissue on the back of the tongue. So it stops it from growing back again. So I quite like radiofrequency ablation. The problem with radiofrequency ablation is that it takes a long time to heal. At the start, it swells up quite a lot because you haven't taken off the lingual tonsil, you just ablated it. So the first 2 or 3 weeks, it swells up rather than feeling better, it gets worse. And so you often need steroids and things like that to shrink it back down again. And so you can get through that recovery period. And for a long time, it stays much the same until you get to about 3, 4, 6 months down the line, when the scar tissue, that sort of the white fibrous stuff, shrinks it all down, stops it from swelling up again. And that's when, I can feel like I can breathe a little bit better. And that's when radiofrequency ablation works better. So it does take time, and you get that initial period of, oh my God, I just feel like I can't breathe very well. So it's a much smaller sort of 10 to 15 minute operation, but it takes a long time for it to work. The next thing in my ladder of things that can help tongues is something known as Coblation. Coblation is really good. What you're doing is you sort of disintegrating the tissue around the back of the lingual tonsil particularly. And you can sort of swipe away and remove all that tissue. But the problem is that if you leave it like that, the lingual tonsil weirdly tends to grow back again, a bit like adenoids tend to grow back again sometimes. There's about a 5% risk of adenoids growing back. The same thing with lingual tonsil, it can grow back. So some people, what they do is they cauterize the base. So you're cauterizing onto the actual tongue muscle. So you're sort of burning it really. So firstly, you've got a big open sort of wound there. You haven't got like a scarred bit of area and sort of slough over as you do with radiofrequency ablation, the Celon technique. But with Coblation, you've got this big wide wound on the back of the tongue, and then you're cauterizing, burning the tongue itself rather than the lingual tonsil on top. And that's to try and avoid it coming back. So it's a lot more painful. And I think it does swell up quite a lot. So a lot of people have more pain after Coblation, at least I've noticed anyway, more pain after this operation than you would with radiofrequency ablation. It's not very nice at all. You can use Coblation, however, to go into the tongue muscle itself. It's quite hard with the normal coblating wand that people use for tonsils sometimes. Again, I talk about that in my tonsillectomy book. I've got this tonsillectomy book in my head because I'm always writing it at night. But I'll come back to that some other day. But you can go into the muscle a little bit, but it's not nice, obviously, going into the muscle. But if you do need to go into the muscle, there's a possibility of using the Coblator to go into the muscle tissue itself. There is a thing called a SMILE technique, which I think was done in Australia some years ago, where you put the Coblator underneath the surface of the tongue into the muscle layer underneath, between the two nerves and blood vessels of your tongue. So you've got your tongue coming out like this, and the nerves and blood vessels go along the side. So you can actually make a cut in the middle of the tongue there, put the Coblator through the hole and start sort of vaporizing, disintegrating, whatever you want to call it, the muscle of the tongue in the middle. That sounds horrible, and it is horrible. It's not very nice, but it's a little bit less painful than making a big open wound on the back of the tongue, because you've still got the skin on top. You're just letting everything collapse in like that. The thing I don't like about that, because you're not sure exactly where the nerves are, you can't be certain that you're not going to damage them. And it's not a technique that I like using because I'm just scared of damaging the tongue and having tongue weakness on one side, not being able to swallow or speak properly afterwards. So it's I worry about that. The other thing you can do, which is more of an open wound, you can use a robot. Some people will know about the Da Vinci robot, which says this robot that goes into your throat and you can see everywhere what you're doing. You remove the lingual tonsil with the laser typically, and then you cut through the muscle and remove the muscle so that the tongue shrinks down so it doesn't keep falling back. Professor Vicini and Giovanni over in Forlì in Italy, who I went to see last year, there's a video about that here somewhere. What they suggest is roughly about 7 centimeters cubed of tongue tissue to reduce before you get the result that you're really looking for. And you have to go right through the whole surface. It's sort of a big area that you have to take out. Obviously, there's a risk of damaging the nerves and things like that. But if that is your only option at that stage, well, that's the next step. You can bring the whole jaw forward. And there's a video here about how successful is surgery. I'll put that video up here. And this is a BiMax procedure where you, instead of operating on the tongue itself, you bring the whole facial skeleton forward. You break the bones around here, the jaw here, and just bring everything forward a little bit, and it pulls the tongue forward. And that seems to work because he's pulling the whole thing forward and you're not actually operating directly on the tongue. There are lots of obviously side effects of breaking your face in several places and bringing it forward, but that's another option as well. And you can see we're sort of going up a ladder here of impact to your body. Now we do have these hypoglossal nerve implants, particularly the new one that we've got available, the Inspire device. It looks like a bit like a pacemaker with a wire that comes up to the nerve to your tongue. So you're not actually operating on the tongue itself, you're operating on the nerve to the tongue. And that's quite useful because what you're doing is that every time you stop breathing, the pacemaker picks up on that, activates this nerve that goes to your tongue, and it protrudes the tongue out away so you can take a breath without you needing to wake up for it. It picks it up before then, so you can reduce your sleep apnea that way. Actually, we're about to start this in the middle of June. So our first patient is in the middle of June. We had our multidisciplinary meeting yesterday. It's all very exciting. We set up our protocols and say, that these are the things we're going to accept, these are things we're not going to accept. So our first few patients are happening in the middle of June. I'll tell you all about it soon, and I might even do a little video when we go to Germany for our last bit of training that we have to do. But that's beside the point. So that's another thing we can do for tongue-based surgery. You're bringing the tongue forward, so it's the next sort of step up. And I've mentioned or hinted at different videos where I've got new implants that we're thinking about, which don't just operate on that one nerve, that one hypoglossal nerve, maybe two nerves, like the Nixua Genio device, which hopefully we're going to bring through soon. And there's a new trial that's come up that shows that that works very well. And there's also another implant, which I'm not allowed to tell you, because if I tell you, I have to kill us both. So, and the company will get very upset. But these are using other nerves, not just the hypoglossal nerve. And so there's all sorts of things that you can do for tongues if that's your only problem. But it's hardly ever your only problem. It's normally a combination of things. But hopefully that sort of gives you a brief, sort of broad understanding of tongue-based surgery. And hopefully that's useful to someone out there. Oh, I forgot about something and my battery's running out. I'll talk about that in the next one as a short video. Bye-bye.